doing a rapid revision of vulval cancer, a rare malignancy. Vulvar cancer is one of the rarest gynecological cancer, representing less than 1%, and it is most common in postmenopausal women. What are the precursor lesion? It is vulvar intraepithelial neoplasia. It is the precursor lesion, and HPV related vulvar lesions are more common in younger women. Okay, International Society for Vulvovaginal Disease first classified it as vulval intraepithelial neoplasia as 1, 2, and 3 type, and then differentiated type. In 2015, they have reclassified into low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion that include both vulval intraepithelial neoplasia type 2 and 3, and the differentiated type. So, what is the vulval intraepithelial neoplasia? In vulval intraepithelial neoplasia, there is abnormal proliferation of the cells that have not breached the basement membrane, and there are two types. Usual or and the differentiated type. The usual type is the basalite or warty type. It is 40% and multifocal, most common in the young patient, and is due to a human papilloma virus infection. Risk factors are smoking and immunosuppression. It is mostly associated with sin, win, and in. ठीक है, cervical intraepithelial neoplasia, vulval intraepithelial neoplasia, and anal intraepithelial neoplasia. First line of treatment is the excision, and second is the imiquimod mode. In the differentiated type, it is most common. It is the keratinizing type or the differentiated type. It is 60% unifocal. It mostly present in the old age. Lichen sclerosis and planus are mostly involved in that. And again, the treatment is first surgical excision, and then second steroid or um, uh, uh, steroid treatment or emollients. Then 9 to 18% of the wind convert into CA. Okay, what are the about vulval intraepithelial neoplasia? It is it is 4 to 6% of all genital cancer, and it is very rare, only 1%. Age group most common in the 6 to 7 decade, mostly postmenopausal women, and increased incidence of the other cancers like cervical intraepithelial neoplasia or anal intraepithelial neoplasias. What are the risk factors in the young women? The risk factors are the sexually transmitted diseases, and the most common is the human papilloma virus, and mostly the 16 and the 31 type, and the herpes simplex virus, smoking, alcohol, and immunosuppression. In elderly women, it is the lichen sclerosis which is the main culprit, along with the chronic vulvar pruritus or vulvar dystrophy. There are types squamous cell carcinoma, melanoma. Second most common is the melanoma. So it is again the MCQ. The most common type, which one is the 80% squamous cell carcinoma, 80 to 90%. Melanoma, it is only 2 to 5%. Okay, and the adenocarcinoma, which forms the Paget's disease, and so most common is the squamous cell carcinoma. It is the MCQ. Then, what are the clinical features? Clinical feature is the pruritus, most common, and the initial symptom. Okay, and vulvar swelling, lump, ulcer, single or multiple, and most common site is the labia majora. Second is the clitoris and the perineal area. And what is the investigation of the choice? It is the MRI or the CT. Okay. Now let's come to the staging of the vulvar cancer. Stage 1 is confined to the vulva. In the stage 1, it is invasion less than 1 mm, and size is less than, dimension is less than or equal to 2 centimeter. And what is the management? The management is the wide local excision. In stage 1b, the invasion is more than 1 mm, and the size is more than 2 centimeter. The management is radical vulvectomy along with sentinel lymph node procedure. Stage 2 involve lower one third of the urethra, vagina, and the anus. And in it, we do the radiotherapy with or without concurrent chemotherapy, followed by radical vulvectomy. Stage 3A. Stage 3 has three classes: 3A, B, and C. 3A involves the upper two third of the urethra. bladder mucosa upper two-thirds of the vagina, rectal mucosa, and regional lymph node less than 5 mm. 3B involve lymph node more than 5 mm, and 3C involve a lymph node with extra capsular spread. For 3A, B, and C, we do the radical vulvectomy plus inguinofemoral lymphadenectomy and adjuvant radiotherapy to groin and the pelvis. Stage 4 involve 4A and 4B. In it, the lymph node in 4A, lymph nodes are fixed or ulcerated, and in 4B, distant metastases are present. For the 4A or 4B, we do the biopsy followed by primary radiation with or without chemotherapy. For vulval recurrence, we do the surgical resection for 2 centimeter tumor-free margin. In pelvic recurrence, there is no role of surgery. Chemoradiotherapy is the choice.